Hey guys, so I am going to be doing an ER to ER nurse report on a couple cardiac patients. I'm going to start off by comparing two patients that have similar things going on, and I want to talk about why I would do certain actions. So the first patient, if I were giving report, I would say you have a 59-year-old male. He came in with chest pain, felt like tearing in his chest. Doesn't have a cardiac history, but does have diabetes mellitus and colon cancer. His bilateral BPs were negative. The CTA was negative. His troponins were positive. His EKG was normal sinus rhythm. So we diagnosed him with an NSTEMI, and we started him on heparin. He's on 18 units per kilogram per hour. Started at 9 a.m. His anti-XA is due at 3 p.m. He does have a port on the right chest wall, and it does draw. His plan is admission. He's waiting on a bed, and I have him on a monitor. His pump is on an IV pole. He knows to call to go to the bathroom. Wife is at bedside. He's A&O times 4. He's ambulatory. I ordered him lunch, and I just took his blood glucose. It's 136, so you don't need any coverage. So that's my first patient. The second patient that I'm going to give a report on, I would say she's a 28-year-old female. She came in for right leg swelling and pain in her leg, especially when walking. She takes birth control and she smokes. She got a deep vein ultrasound. Turns out she has a DVT in her right leg. So we started her on heparin, 12 units per kilogram per hour. I started it at 1 p.m. Her anti-XA is due at 7 p.m. Plan is to admit her for bridge 2 anticoagulation therapy. We're waiting on a bed. She's A&O times 4. She's not on the monitor, but her pump is on a pole. She does have a nicotine patch already in place, and her mom's at bedside. P.S. Her mom's a nurse. So it's super short. It's to the point. Both of those are. It's a lot less detailed. I want to talk about a few reasons why I did do some things versus not other things, but I want to start off with the port access and IV access. So for the first patient, I talked about how he has a port and that I accessed it, but I didn't talk about IV access with the second patient. So it is standard that if you start heparin, no matter where you're at, you have 2 IV lines, preferably, right? But generally, you're going to have that. If you don't have 2 IV lines, that's when you should mention it. You should be like, hey, P.S., they don't have IV access. They have just the 1 IV access, and the heparin's running through that. So if I don't mention that in report, that's because they have that, because that's what they should have. And I'm not going to take the time to talk about 2 IVs. I didn't mention it on the female, her IV access, because it's not necessary. She's going to have 2 IVs. She's got one of them running heparin. The other guy, he's also going to have an IV and his port access because he is getting heparin. And the reason why I mentioned the port is not because I want people to know he has 2 IV accesses. It's because that's a nurse draw. So I need that nurse who's receiving a report to know that she is receiving a patient when the anti-XA is due. She has to go draw it. Now I know sometimes on the floor, the nurses don't do the blood draws and the techs don't do the blood draws. But in the ER, nurses and techs do blood draws. So that's a pertinent piece of information. The other thing that I mentioned that I think is super important is the times that things are due in the ER are super important. A lot of things are time sensitive. So if you have a patient that has a medication that has to be at a specific time, anything that's timed, your troponins, they're timed, your anti-XAs or your coags, whatever it is, like your redraw, so that you can follow your heparin nomogram. Those kinds of things are all timed. It's really important to let the nurse know when the next one is so that they aren't spending their time looking that up. And it's not an obvious thing because every patient has a different time. So it's an important thing to put in there. I did mention that my 59-year-old male was ambulatory. I didn't mention it in my key points for my 28-year-old female. The first reason why is because I literally said it in her chief complaint. She came in for right leg swelling and pain, especially while walking. That means she's ambulatory. And second of all, I mention it for him because he's got a lot of things going on. He has diabetes, he's colon cancer, he's got an NSTEMI going on, he's got a lot of things going on. There's more likely of a chance that he might not be ambulatory, whereas she's 28, she's healthy, she's ambulatory. I don't need to waste your time in report to talk to you about that. Why do I include IV poles? So this is super important to me. I don't always get this in report, but I prefer to get it in report. So if I have a patient who is on a medication that I can't just stop and they have to get up and go to the bathroom, it becomes an emergency for them, or a sense of urgency for them, because they usually try not to call you until they really absolutely have to go. And so they've called you and they really have to go, and you've got this medication that has to go with them to the bathroom, and you don't have a pole. I don't know how everybody else's ERs work, but in all the ERs that I've worked in, pumps and poles can be a little bit difficult, along with pillows, to find quickly. So I always make sure that if it's something like that, that I let the nurse know, hey, they've got a pole. And if they don't have a pole, I'm like, hey, they don't have a pole. That might be something that you put higher on your priority list of things to find before they have to go to the bathroom and you find yourself in that conundrum. So the other thing I want to talk about, I talked about bilateral BPs in my first patient. I did say he came in, he had tearing chest pain. It's a classic sign and symptom for a dissection, or a AAA. So you want to let them know that even though that was the sign and symptom that they came in with, we checked into it, it was negative. It was addressed and negative. So I also said that the CTA was negative. Notice in the female that I have, I didn't say we worked her up for something completely different and found out that was negative, because it's just not pertinent, and because we probably would have just gone straight down that route and found that to be the case. Generally, one leg swelling tends to be a blood clot. So the other thing that I think is unique and different to ER nurse reports that I included was I said a plan of care for the girl. I didn't say a plan of care for the guy. Should you do a plan of care for all your patients? Yeah, probably, but you're going to want to relay that probably to the floor a little bit more. In the ER, you have a patient with a STEMI, it's black and white. You're going to be monitoring their heart rate. You're going to be doing the heparin. They are going to bridge. There's a whole, it's not variable or as variable for a STEMI as to what it is you're going to be doing. So as far as a DVT in a young girl, chances are that she is going to be getting the heparin bridged therapy. I mentioned that, but it could also be that we just send her home with some sub-Q Lovenox or whatever, that she's going to be following up outpatient if it's not occluded that much or if it's not that big of a deal. So there are multiple different routes that we could have potentially gone with that patient, and I needed to make sure that I let them know this is exactly the plan of care. This is what the doctors have decided the patient knows about it. And then as far as the last two little things, I generally try to give the nurse a little something about the patient that I noticed that was different, if there's something different. I did say, hey, he had lunch, his blood glucose was 136, he doesn't need coverage. Could they look that up? Yep. But this way, when the lunch comes, because the lunch is coming, I ordered it, it's going to be here soon. They don't have to run around and look for a glucometer. They know I've already taken the glucose, and they know they don't have to cover, so they don't have to, go get the insulin. It just helps them set up their to-do list for what to do next. And for the girl, I mentioned mom is a nurse. This is not a slam on nurses, but it's important because when you walk into a room of a healthcare professional, and they've already established that they're a healthcare professional, it's a level of courtesy to speak with them in regards to some of the things that you're doing. I may not always explain to my patients, hey, I'm going to be taking your blood pressure every 5 minutes because of this medication you're on, or whatever. But I do try to say it when I have a healthcare professional there, when I say, hey, by the way, just so you know I'm giving this super intense medication, and I'm monitoring the blood pressure every 5 minutes, just so they know. Like, it's almost like a way to help them relax and be like, okay, this nurse knows what they're doing. They're not forgetting about my loved one. So I think of it as like a professional heads up for that nurse who is taking over, and for the nurse who's sitting in the room, who would probably want to be updated on some of the things that we don't always update our family members on because they don't really know or understand. So that was my first report.